contains two primary components. There is the physician quality and resource use reports, and then there's the development and implementation of a value-based payment modifier, or simply a value modifier. So the Value Modifier program supports the transformation of Medicare from a passive payer to an active purchaser of high quality and more efficient healthcare through the value-based purchasing initiative. I'm sorry, my mouse is kind of stuck. I apologize. Okay. Um, so the value modifier was applied only to group practices with 100 or more eligible professionals during the initial payment year, and solo practitioners or group practices with 2 to 90 eligible professionals remain unaffected by the value modifier in 2015. So CMS basically believes that this modified approach will allow it to gain more experience with the program, and it would allow for more streamlined outreach and education during the first year and enhance physician acceptance of its methodologies and approach. So the program will be applied to additional physicians in 2016, and the group size has been reduced to 10 plus providers for the 2014 calendar year. As required under the statute, the program will be applied to all physicians by 2017. Therefore, providers who are solo practitioners or in small group practices are encouraged to become familiar with the value modifier and to start participating in the physician quality reporting system, which CMS will use as the basis for calculating the quality component of the modifier. So for purposes of defining group practices, CMS defines eligible professionals as not only physicians, but physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, certified nurse midwives, clinical social workers, psychologists, registered dietitians, as well as physical and occupational therapists, speech pathologists, and qualified audiologists. CMS basically chose this broader definition since it aligns with the PQRS, and since this definition is not limited only to physicians, smaller practices that rely heavily on ancillary staff will they need to verify whether they fall under the initial target of 100 plus eligible professionals for calendar year 2013 or 10 plus eligible professionals for calendar year 2014. In 2012, CMS provided confidential feedback reports to all successful PQRS participants to demonstrate the type of information that would be used to calculate the value modifier. In 2013, the initial performance period began. Services that were provided in 2013 will be used to calculate value modifier in 2015. 2015 will be a period where CMS can use its discretionary authority and apply the modifier to larger group practices only. Then in 2016, they will continue to apply the modifier, but like I mentioned earlier, the group practice size will drop to 10 plus providers. And by 2017, value modifier will apply to most or all physicians who submit claims under the Medicare physician fee schedule. So these are the policies that govern the value modifier program. And I wanted to show you both the policies for 2015 as well as 2016. If your practice has already started participating in this program in 2013, then the policies that would apply would be the 2015 policies. And if you're planning on participating in this program this year, then the 2016 policies would apply. So this, it basically just summarizes some of the information that I've already provided you, and but I just wanted to give you a side-by-side comparison for you to get a better sense of what these policies look like. Sorry, my mouse here is not working optimally. I'm going to go into greater detail about how the value modifier is calculated, and I'll discuss the cost measures. But it's important. One of the important concepts of value modifiers is quality tiering, and I'm going to talk a little bit about this as well. It's interesting to note that in the first year of the program, the payment at risk is 1%, and then the following year it's compounded and it doubles. And with all of Medicare's programs, the payment adjustments tend to be compounded, so the financial impact can be pretty significant. In determining application of the modifier, group practices have to make two decisions. Firstly, the group needs to decide how it would like to engage in quality measurement in the measurement year, and then it must decide whether it would like a percentage of its Medicare payments to be based on its quality and cost performance during the measurement year. These decisions drive the amount of the modifier. So to be eligible to to avoid penalty and to earn the incentive, professionals must meet any one of these criteria. So they either need to self-nominate to participate in the PQRS group practice reporting option, or GPRO, by October 15th via the CMS Communications and Support website, and they must satisfy the reporting criteria for the PQRS incentive program, either via the GPRO registry reporting option or the GPRO web interface. These are the only two PQRS reporting options that are available to groups that are this size. And this, again, is for the reporting year 2013. The second option is for groups to self-nominate to participate in the GPRO and successfully report at least one relevant PQRS measure. Or the third option is to elect to be analyzed under the PQRS administrative claims-based reporting option. Under this option, CMS will automatically analyze Medicare claims to determine a practice's performance on a pre-designated set of 17 primary care-focused quality measures, which include 3 composite outcome measures. Unlike traditional PQRS reporting mechanisms, this option requires no effort on the part of the group practice other than electing to be analyzed. And this is a temporary reporting mechanism that CMS does not plan to offer in the future. The group practices that do not meet these criteria will be subject to a payment adjustment or a penalty. So this slide shows how value modifiers are calculated. Since we're already in 2014, I wanted to focus on what the eligibility criteria for this year are. And so the group practice needs to be a minimum of 10 providers. If they are PQRS reporters, then they need to self-nominate, and I just went over the details of how this works. I'm sorry, I got booted out. I apologize. I'm not sure what's going on today, but I apologize for that. So this slide basically is a summary of all the information that I shared with you, but it gives you a nice little graphic of how the payment is calculated and what how to avoid a downward adjustment. Okay, so practices that voluntarily elect the quality tiering approach can elect to have CMS apply a value modifier based on a calculation of the group's performance on a composite of quality and cost of care measures. Um, CMS will calculate a quality composite score that is based on measures reported through the GPRO or through the administrative claims reporting mechanism. For groups that opt to report on only one measure through the GPRO, CMS will default to the administrative claims measures since it would not have sufficient quality information to construct a quality composite. Similarly, if a measure is new to PQRS, CMS will be unable to calculate a benchmark and performance on that measure will not be included in the quality composite. So then CMS also evaluates all group practices on 3 outcome measures that are included under the administrative claims option. And these include an all-cause readmission measure. This measure estimates the hospital level risk standardized rate of unplanned all-cause readmissions for any eligible condition within 30 days of hospital discharge for patients who are 18 or older. An acute preventive quality indicator composite and quality composite scores will be constructed by classifying each group's quality measures into one of 6 domains. And these domains are patient and family engagement, patient safety, care coordination, population and public health, efficient use of healthcare resources, and clinical processes and effectiveness. Each measure will be weighted equally within each domain, and each domain will be weighted equally to form the quality composite. In cases where a group does not report measures in 1 or 2 domains, the remaining domains would be weighted equally, and if the group only reports measures in a single domain, the domain would be weighted 100%. So these are really complex algorithms, and but I just wanted to share these with you, not with the expectation that you would actually remember these, but just so you have an understanding of how value modifiers will be calculated. So similarly, on the cost side, to calculate the cost composite score, CMS will evaluate 5 measures. A total per capita cost measure, that is the total overall costs of attributed beneficiaries, and total per capita cost measure for beneficiaries with 4 chronic conditions. And these conditions are COPD, heart failure, CAD, and diabetes. Total per capita costs include payments under both Part A and Part B, but not Medicare payments under Part D for drug expenses. Whether these costs are truly and directly attributable to the group practice is still debatable. CMS will use the plurality of primary care services methodology to attribute beneficiaries to a group practice for purposes of cost management. And then CMS also uses this method to attribute patients to accountable care organizations under Medicare's shared savings program. And then they apply various adjustments to cost data, such as a payment standardization methodology, which aims to remove local or regional price differences that may cause cost variations that a physician cannot influence. CMS will also employ the hierarchical condition categories, or HCC risk adjustment model. And we will actually be, our next Insights topic is Medicare Advantage, and we're going to be talking more about hierarchical condition categories in that presentation as well. So the HCC model adjusts for medical condition risk, patient age, gender, end-stage renal disease status, reason for Medicare eligibility, whether it's age or disability, and Medicaid eligibility status. The HCC model is regularly updated to reflect changes in treatment patterns as well as costs. And this is the same model that CMS used in confidential resource use feedback reports that were distributed to physicians. And this is a summary of what the two composites look like and how they add up to create the value modifier score. I just went over all these details. In order to achieve the legislatively mandated budget neutrality for the program, positive adjustments to groups of physicians would be offset by negative adjustments to other groups of physicians. Since the total sum of downward adjustment is unknown at this time, CMS cannot determine specific upward payment amount percentages. So CMS will divide the total quality and cost composite scores for each group practice into 3 tiers based on whether the score is above, not different from, or below the national mean. The CMS will give groups that are high quality and low cost the highest upward adjustment. And to ensure that value modifiers encourage physicians to care for the severely ill beneficiaries with complications, for particularly complicated cases, CMS also will apply an additional upward payment adjustment for groups of physicians furnishing services to high-risk beneficiaries. So this framework basically is designed to focus on statistically significant outliers, that is, at least one standard deviation from the mean. And I know this is really hardcore statistics, so I apologize. Like I said, I just wanted to share with you how these calculations are done. You're not really expected to remember all these algorithms. So as required by the statute, CMS has provided confidential physician feedback reports to certain physicians and groups of physicians since 2010. The reports quantify and compare quality and costs among physicians and physician group practices that are relative to the performance of their peers. In September 2011, CMS provided physician feedback reports, which were also known as quality and resource use reports, to 35 large medical group practices. Each practice had 200 or more physicians. And these practices participated in the PQRS GPRO program in 2010. In March of 2012, CMS disseminated feedback reports to about 24,000 individual Medicare fee-for-service physicians in the Midwest. And then in early 2013, CMS did disseminate the same reports to smaller groups of 25 or more professionals in still mostly in the Midwest, but also in California. And these reports contained the PQRS measures that physicians had submitted via any of the PQRS reporting methods in 2011, as well as data related to the 28 administrative claim measures that CMS had included in the report since 2010. So they will continue to disseminate these reports moving forward as well. And these preview some of the methodologies that were finalized under the Value Modifier program, including PQRS and administrative measures, measure comparisons to national benchmarks. So in the middle of September last year, CMS disseminated the physician feedback report at the individual at the TIN level to all groups of physicians to, with 25 or more professionals. And then in the fall of 2014, CMS will disseminate the same reports to even smaller groups. So basically, they've started with larger groups and then are funneling down to smaller group practices. So reporting data at the group level, the focus at the group level is really on preventive care as well as managing chronic disease. And the quality measures are extracted from PQRS data, basically. Sorry, I'm really having a hard time with my computer today. So reporting at the individual level, if 10 providers bill from the same TIN, CMS will auto-enroll them. And this is a new step that they're taking for 2014. And one of the reasons why we wanted to talk about this topic today is because our concern is that not a lot of Medicare providers are fully conversant with this program, and it has, like I said, it has a potentially huge financial impact. The qualifier, though, is that at least 50% of the eligible professionals within the group must report measures individually, and at least 50% must successfully avoid the 2016 payment adjustment. So this, again, is just a summary of how eligible professionals can report on the measures that are available to them. It's either through claims, through qualified registries, through their EHR systems, or through clinical data registries. This is the new initiative for calendar year 2014. So there's still a lot of concerns around this program. While CMS has taken steps to ensure gradual implementation of the program, there are concerns about whether it will be able to collect and analyze enough relevant and meaningful experience by the time it is required to apply the modifier to all physicians in 2017. Physicians are already required to comply with multiple quality reporting mandates while also facing the threat of multiple payment penalties and cuts. Premature implementation of the value modifier paired with these mounting regulatory requirements and payment cuts will potentially lead to further confusion both for patients as well as for physicians. The HRS, of course, continues to remain involved in efforts to meaningfully define and measure quality and cost, as well as to ensure that these activities do not unintentionally detract from the time and resources needed to ensure the delivery of safer, more efficient, and more efficacious care. So as required under the ACA, CMS also will be phasing in public reporting of physician quality by initially posting on CMS's Physician Compare website in 2014. Quality measures that are reported by group practices and ACOs that participate in PQRS GPRO web interface, as well as patient experience data for ACOs and group practices, will be available on this website. And so there is a potential for a provider's basically there's a financial risk exposure for the provider if he or she is not listed on this website, and that basically is construed to mean that the provider did not meet any of the quality measures, and it can potentially affect his or her practice patterns. So moving forward, it is estimated that they're going to, by lowering the threshold, will cause about 60% of the physicians to be included in the Value Modifier program in a calendar year 2016. So that's still 2 years out. And groups of physicians with 100 or more eligible professionals could receive either upward or downward adjustment. However, only upward adjustment would be applied to smaller groups of physicians between 10 and 99 eligible professionals. The other sort of thing to watch in the months to come is that commercial payers are also creating processes and protocols to follow suit with implementing value-based healthcare. And so that also could affect practice patterns moving forward. I apologize, my technical support today has not been the best, so I'm really, really sorry about that. But if you have any questions, this would be a good time to post those. And since we're a small enough group, I'm going to go ahead and unmute everybody. So if you have any specific questions, I'd be happy to answer those. So you're all unmuted now. Feel free to speak. Any questions? Okay. This is probably a very dry topic, just with a lot of data and statistics, and I apologize for that once again. But like I said, our intention really was to start creating awareness about this program so that providers aren't caught off guard. And this doesn't come as a surprise at the end of 2014 when they're assessed some kind of a payment adjustment. So if there are no other questions, then I'll wrap this up. Next week, we're going to be talking about Medicare Advantage, and we'll actually be sharing a case study with you. So please do join us. And my apologies once again for my really messed up computer today. Thank you. Bye-bye.
Thank you. Thanks.